Hey guys, it's me Samya and today we're going to discuss about the question myeloproliferative neoplasms. Starting off with the definition, which is myeloproliferative neoplasms are neoplastic proliferation of mature cells of the myeloid lineage. Emphasize on the mature cells, which includes RBCs, platelets, megakaryocytes, granulocytes, which consist of neutrophils, eosinophils, and basophils. And we do not include monocytes in this question because monocytes will be classified under histiocytic and dendritic tumors. So myeloid neoplasms will originate in the bone marrow. However, on the other hand, lymphoid neoplasms they can originate in the bone marrow, thymus, or even inside tissues. So this flowchart that I have drawn over here explains what we're exactly going to discuss about. So we know myeloid lineage and the lymphoid lineage. In the myeloid lineage, we have our RBCs, megakaryocytes, platelets, neutrophil, eosinophil, basophil, and mast cells. And notice how I have circled only the mature cells. So these mature cells, if there's neoplasms, these mature cells increase, and that is what we're calling it as myeloproliferative neoplasms. So let's say if we have an increase in RBCs, so it's known as polycythemia vera. If we have increase in platelets, it's essential thrombocythemia, and if it's increase in megakaryocytes, it's myelofibrosis. In an increase in these granulocytes is chronic myeloid leukemia, and in the mast cells, it's mastocytosis. And this, as we know, is the lymphoid lineage. Moving on to the next, why is it happening? It's because of gene mutations. For example, in chronic myeloid leukemia, there's a gene mutation in which is the translocation of chromosome 9 and 22, which is the Philadelphia chromosome, and this will lead to excessive proliferation of the white blood cells. And other myeloproliferative neoplasms are caused by JAK2 kinase mutation, and we know the JAK-STAT pathway, which is a growth pathway, and this will lead to its constant activation and cause overproduction of the different blood cells. Next slide is important. Over here, we're going to discuss how is this disease going to progress. So at first, there is an excessive proliferation of all the cells called panmyelosis in the bone marrow, and then one myeloid lineage will become dominant. We also have high cell turnover, and that leads to gout because we know that DNA breakdown gives uric acid. So increased DNA breakdown will give increased uric acid that can result in gout. After this, it can lead to pancytopenia, which will be dominance of the one cell type will suppress the others, and this will lead to pancytopenia, low blood cell counts. So this can result in anemia, bleeding, infections. After this, we will also see the spleen and liver starts enlarging because they're doing hematopoiesis now, which is known as extramedullary hematopoiesis, in order to compensate for the bone marrow. And then we will see myelofibrosis, in which the bone marrow will undergo fibrosis, and this will occur because the marrow cannot keep up and it keeps reducing the blood cell production. That's why. And usually in these cases, bone marrow transplant is often required. And as this disease progresses, eventually there's a huge chance that the patient can get acute myeloid leukemia, which is mutations in the stem cells due to overproduction can lead to acute leukemia, as it is written in this point. In the morphology of the myeloproliferative neoplasms, early stages we would see a hypercellular bone marrow, but then later, as we discussed, the bone marrow becomes fibrotic. Now, there are five types of myeloproliferative neoplasms that we're going to discuss. Starting off with chronic myeloid leukemia, in which there's an increase in the granulocytes number. And then there's polycythemia vera, in which we have increased RBCs, and then essential thrombocythemia, where there's an increased number of platelets, primary myelofibrosis, where there's an increased number of megakaryocytes, and mastocytosis, where there's an increased number of mast cells and tissues, and this is the only solid tumor that we have out of the five. Starting off with chronic myeloid leukemia, in this the mutation is happening in the fillet. It's the translocation of the chromosome 9 and 22, and this leads to a BCR-ABL fusion gene, and that increases the tyrosine kinase activity, which eventually leads to increase in the cell proliferation. And it's very important to know which cells are going to be increased in each one of these neoplasms that we're going to discuss about. In chronic myeloid leukemia, it's granulocytes, especially basophils. And the treatment can be imatinib, which blocks the tyrosine kinase activity. In progression of chronic myeloid leukemia, it will start as a chronic phase. So first we have mature number of granulocytes, which are the mature cells, and decreased number of myeloblasts. But however, as the disease progresses, it will turn to a blast crisis. And now we have increased number of myeloblasts and decreased number of mature granulocytes. Eventually, the spleen starts enlarging, and this signals that the disease has progressed way further, and this can transform into acute myeloid leukemia in 2 by 3 of the cases, or acute lymphoblastic leukemia in 1 by 3 of the cases. This is because of the mutation in these pluripotent stem cells. Next is polycythemia vera, in which we have increased RBCs, erythrocytes, and this is associated with JAK2 kinase mutation, JAK-STAT pathway overactivation. And obviously, if you're going to have increased RBCs, that means hyperviscosity is going to happen. And symptoms such as blurry vision, headaches, venous thrombosis risk, especially in the hepatic and portal veins. This can also lead to hepatosplenomegaly because of the congestion, and itching after showers because of histamine release. Treatment is that we use JAK2 inhibitors to inhibit this JAK-STAT pathway, and it leads to a good prognosis. However, if treatment is not on time, death will occur within 1 year. Disease progression, this can also progress to acute myeloid leukemia or myelofibrosis. Now we need to distinguish between reactive polycythemia versus polycythemia vera. Reactive polycythemia, due to high altitude or lung disease, in this the saturation of O2 is low, and that's why EPO is increased. In polycythemia vera, the saturation of O2 is normal and erythropoietin levels are decreased, whereas in reactive polycythemia, that is due to ectopic EPO production from renal cell carcinoma, the EPO is going to be high and the saturation is going to be normal. Then we're coming to essential thrombocythemia. In essential thrombocythemia, there's an increase in number of the platelets, and that is also associated with JAK2 kinase mutation. This can increase the risk of thrombosis or bleeding, but it does not progress. It rarely progresses to myelofibrosis or acute leukemia, and there's no risk of hyperuricemia or gout because the nuclear acid content is low in platelets. That's why. Coming to number 4, which is primary myelofibrosis, it is a neoplastic disorder with the overproduction of megakaryocytes. This is also associated with JAK2 kinase mutation in about 50% of the cases, while the rest are idiopathic. This disease causes fibrosis of the bone marrow, not secondary to other conditions, which disrupts normal blood production. Now, coming to the course of the disease, this disease progresses from a profibrotic phase where megakaryocytes will produce excess platelet derived growth factor, stimulating the fibroblast activity. In the fibrotic phase, however, the bone marrow becomes increasingly fibrotic that leads to pancytopenia and extramedullary hematopoiesis, mostly in the spleen, which causes splenomegaly. In the lab findings, we see leukoerythroblastic smear, which is immature white blood cells and RBCs from extramedullary hematopoiesis, as we just discussed, and teardrop shaped RBCs because cells stretched as they exit the fibrotic marrow. And I put a picture, you can see the teardrop RBCs. Lastly, we have mastocytosis, and it is a condition which is characterized by the proliferation of mast cells. They're also called mastocytes in the bone marrow and various tissues and organs. Mast cells are a type of white blood cell, as we know. They're similar to basophils. They release heparin, which is an anticoagulant, and histamine, which lead to vasodilation and increased vascular permeability, and this results in edema and rash. Now, there are two main types of mastocytosis, which is cutaneous mastocytosis that affects only the skin, and systemic mastocytosis, which involves multiple organs. Now, the symptoms of cutaneous mastocytosis include skin lesions, itchiness, paroxysms of arterial hypotension due to excessive histamine release. However, in systemic mastocytosis, we see that patients may experience more severe symptoms such as anemia, bone pain, gastrointestinal issues, and an increased risk of infections. And yeah, that's it.